Okay, hello everybody. I'm Alexandru Mischie. I'm the chair of the telecardiology working group from the ISFTH. I'm very happy to have so much colleagues, very experienced colleagues today joining us for the webinar to discuss the latest Congress, the ACC 2021 Congress. So without delaying any further, I would like to give the word to my co-host, Dr. Erin Michos from the US. Hi, Erin, how are you?
Hi, everybody, and welcome to this special webinar with the late-breaking clinical trial summaries from the recent American College of Cardiology meeting. So can we go ahead and introduce our first speaker? So our first speaker today will be Dr. Ritu Thamman from the University of Pittsburgh in the United States. And she's going to talk to us about the best of the imaging from ACC 21.
Thank you so much for that wonderful introduction. And I will jump in. So the ACC had some wonderful late-breaking trials. We're going to hear many of them. And in terms of imaging, imaging is key for all the areas, interventional EP, oncology, as was seen in the late-breaking trials. I would preface it by saying that imaging played a supporting role in the trials that were presented at the ACC this year. The first one I wanted to share with you is one out of Canada, which was a brilliant study that answered a very important clinical question. What do we do with these patients who are having AFib and have a CHA2DS2-VASc score that is high? In fact, in this study, they had almost 5,000 patients, and the median CHA2DS2-VASc score was over 4. And they divided half and half. Some were undergoing cardiac surgery. The majority, 2/3, were having valvular surgery, and some 20% were having just plain CABG. And of those patients that were having cardiac surgery, they did left atrial occlusion. And what they found over a median follow-up of almost 4 years, that the risk of actually having a stroke was about a 33% lower. So the incidence, and I will show you on the next page. And the important part to remember is that the benefit of this was on top of the anticoagulation, which the patients were already on. The majority of them, 80%, when they actually were discharged from their incident surgery, were, and then a little bit lower when they were followed up. Something like 76%. So to remember, it's mostly the ischemic strokes that are driving this hazard ratio. And the fact is that even when you have left atrial appendage closure, you have still a 4.6% ischemic stroke rate. So it does not go to zero. But that said, we can offer something to our patients now with clear evidence. These hazard ratios are very tight. And we didn't have any signal that shows worsening heart failure or increased death or increased bleeding as we did in the Galileo that was presented earlier, years earlier. Next, we go on to the tricuspid valve, which is no longer forgotten. This was a brilliant study of 56 patients only. And you can imagine these are very sick patients. And in fact, the majority are women. And by using this very unique EVOKE tricuspid valve replacement system, as you can see, this actually gathers all the leaflets, the cords, and the annulus, because we know in these patients, their annulus also gets dilated because most of these people are having secondary TR. And what this showed in 30 days is that you had significant reduction in your TR grade by echo of more than 2 grades. The downside is that still 22% of these patients had significant bleeding, everything from epistaxis to hematuria, and some required re-intervention. But that being said, we have now gone on to the Transcend 2, and they're already recruiting. So there is hope for the tricuspid valve, and more news maybe next year. Another late-breaking trial was this 4D CT sub-study of Atlantis. And this was answering a very important clinical question. What do we do with these subclinical valve thromboses that we see when we're scanning patients after TAVI? What they did, what they showed was that if they were on abciximab, they reduced the subclinical thromboses. They only found this reduction in those patients that did not have an indication for oral anticoagulant. There was no difference in reducing the amount of the subclinical thromboses in those patients that already had an indication for an oral anticoagulant. So we're not sure what this means clinically down the road, but at 1 year, there was no significance, but we perhaps need longer follow-up. We also do not really know what is the impact of valve thrombosis on durability of the valve. But we know that in this context, there was no extra bleeding seen. So that was something valuable. But again, we as imagers do not have a definitive answer as to what to do with these subclinical thromboses. Another study that I just want to mention briefly is this pirfenidone study that actually looked at reducing myocardial fibrosis in these patients with HFpEF by CMR. Their ECV volume went down, and it was small, but it was statistically significant. This is an under 100 patient study. And so 50-50 in each arm. But we don't know, this is a proof of concept study. We don't know if there's actually going to be clinical benefits. Fibrosis is a difficult endpoint to change. And as you can see, there is a decrease in this EVC in both the controls and also in obviously more in the group that was treated. That is all. And thank you very much. Look forward to everyone else.
Thank you so much, Ritu. So without delaying more, I will give the word to Dr. Rafael Vidal Perez from Spain, which will present updates in digital cardiology. Thank you so much, Rafael, for being here. You have the word.
Thank you for the kind invitation. It started by the end, so I will go to the beginning. Sorry for that. Okay. Well, updates in digital cardiology, fast track. Okay, I have to say that I will show like other times how it was other Congress to make comparison how big is the Congress in impacts and that part. So this is the ESC Congress. I think is the top on Twitter now. AHA is less active, and we can see that the numbers of ACC were highly important this time. I think it's near the ESC Congress, and I think it was a very active debate. I think also the quality of tweets, I think it's even better than other times because there was a lot of discussion, not so many advertisement in the middle with the hashtag. So I think it's more discussion and lively. So I think it's really nice. And another thing that I want to highlight in the digital area, because I have no many digital trials in this year, I have to say honestly. So I went to these fashion things, and we can say that we have the first Congress with Clubhouse discussions and the first Twitter Spaces discussions about the Congress. So we can be happy that there are new ways to discuss, new format, not only on, how to say, on webinar. We can enjoy things with sound like radio, like in the old times. So this is the new radio, that is Twitter Spaces or Clubhouse. It's a new way to discuss, and I think it was a nice experience to discuss with some people of the JACC journals about some trials, and I think we learned a lot. And if I think on innovation and digital things, we have to wait. because the focus on innovation, there is many sessions coming from the ACC on 24th of May. So the Congress is not end. We need to continue to check things there. And we have also e-extras. I will show you, this was the page, and I think it's interesting because there were all the posters commented by the authors in 5 minutes presentation. I think it's a way to create interest on posters. There are many things that you can make all the diagnosis of the cath lab through artificial intelligence tools. We make more or less the same also with echocardiography. So there are many automation coming on different areas, not only on echo. So for the interventions, the bad part of deciding which side, with kind of stenosis you have could be done by a machine instead of QCA. So who knows, new ways to do it. But one of the big topics I have to say on the Congress, I think it was about telehealth. There were many sessions about that, and I think there's the new king on the block because of COVID. I think the people come again to telehealth. It was there. It was not something new, but it was needed to use it more frequently. And we know more things about telehealth. And I think it's a good mechanism to be in touch with our patients. I think it was not a disruptor because it was there, but it enables things to do. And it teaches us how to make things differently, I think, because of the COVID situation. And I think it's a good summary. What are the challenges? Still the same. There were before and now are the same. Some of them were, moved because of the pandemic, this kind of legislation. There was some kind of adaptation for this COVID situation, but the problems are still there. How to regulate this, the cost, the reimbursement. Of course, you need the help of family. So I think it was a different way to do things. There were a very nice presentation about the problems on geriatric population. Do you think you can use this technology or not for all patients? You have, but you have to be aware of some things and how to improve. And this is a good paper published in JAC on how to deal on geriatric thing and also focus on this telehealth. And another lecture I think is interesting, and now this is an example. This session is virtual conferencing, that we are starting to do it more. There are new ways to communicate, like podcasts, but Clubhouse, as I showed you. And I think this is interesting. Of course, we are going to be here for 1 hour and we will lose some attention, but the people start to know that short videos and these kind of things are the things that the people like most to learn. And artificial intelligence was also in the Congress, and there was lectures also about that, on the role of imaging. Somebody is going to touch this. Maybe they need some digital intervention. They don't use it in this case. Maybe the success can come from here. I mean, it's only a teaser. But the only trial that was more or less related with this one about analysis of artificial intelligence of echocardiography versus human, if you can find different factors. It was a study multi-center done by the American Society of Echo. And one of the points is they check the value of some elements for prognostication. They show that the left ventricular the strain was associated with longitudinal strain with the in-hospital death, but not the left ventricular ejection fraction. One of the points probably they say is when they use the artificial intelligence, this is different. The two factors could help us for the prognosis, and probably one of the key points is that when you go with artificial intelligence, you have less variability, and probably you can get some improvement in respect with the manual way to do echo. So this is a nice study. It opens new ideas for research. And I launched some advertisement. I remember there is a digital health journal new coming, that it was the European Health Journal of Digital Health. So don't miss to submit your digital stuff if you have. Thank you so much for your attention.
Great. Thank you so much. That was wonderful. So it is my great pleasure to introduce our next speaker, who is Dr. Mirvat Alasnag from Saudi Arabia. She's going to talk to us about the late-breaking clinical trials related to interventional cardiology. Mirvat?
Thank you, Erin, and thank you, Alex, for doing this time and again, and for inviting me time and again. So there's actually a lot of interventional trials that were presented at ACC this year. I'm going to try to be very quick and not dwell on it. I'm going to try to give you a more clinical perspective for these trials. So this is a slide courtesy of PCR Online and Dr. Nazmi. Thank you very much. They're just wonderful posters that you can find. He's actually posted them on Twitter, summarizing all the trials. So the first one is the Atlantis Trial, and I'd be remiss if I haven't stopped at this trial. It's a very important trial. Approximately 1,500 patients were enrolled. There were really two strata for this trial. Those that were had an indication for oral anticoagulation and those who had no indication for oral anticoagulation. Those who had an indication for oral anticoagulation, such as atrial fibrillation, were randomized, one-to-one randomization, apixaban standard dosing against VKA or vitamin K antagonists. And the other strata is those without an indication for oral anticoagulants, and so they were randomized to apixaban again, and DAPT or single antiplatelet therapy. The primary endpoint was the composite of death, MI, stroke, embolization, et cetera, and thrombosis, but it was also included major bleeding. The dose of apixaban was adjusted if the patient had renal dysfunction, advanced age, or low weight. So when you looked at the primary endpoint in terms of thrombotic events, and when you look at major bleeding events, there was really no significant difference in either strata. Either strategy. So really the apixaban was not superior to the standard of care, which was either antiplatelet or VKA. Ritu had already mentioned this to you guys, the 4D CT scan where they looked at HALT and they looked at realm, but they also did it on all patients and they looked at the mean gradients with echocardiography and tried to find a correlation. Now this is not very different from the Galileo trial. So this is basically the conclusion of the Atlantis trial itself. So as I mentioned, the apixaban was not superior to antithrombotic regimens. Bleeding in terms of safety, again, was similar in both strata. The thrombosis was decreased with apixaban, but it didn't really have any, translate into any clinically meaningful finding. These patients did not have higher strokes. These patients did not have lower strokes, etc. But there's something we need to pay attention to, and that we saw with Galileo more profoundly. But here there was a signal to non-cardiovascular mortality increasing in those who received apixaban compared to antiplatelet in those without an indication for anticoagulation. So when we look at the Galileo trial, I'm not going to dwell on this one, but it was really rivaroxaban against antiplatelet. When you look at all the outcomes, whether you're looking at safety in terms of bleeding, whether you look at thrombosis, et cetera, it was higher in the rivaroxaban arm. And the Data Monitoring and Safety Board terminated this trial early. Again, they also did a Galileo 4D trial, similar to the Atlantis, which showed the realm and HALT and so on. And again, very similar, although there was lower HALT and realm in these patients who received the novel anticoagulant, i.e. the rivaroxaban arm, it didn't actually translate into anything clinically meaningful for these patients. So one thing we take away from this trial is what? That yes, apixaban is not superior to standard of care, but should you need to use apixaban for patients who cannot tolerate vitamin K for whatever reason, it is a reasonable alternative. The thrombosis, as I mentioned, the valve thrombosis and so on, we should probably stop checking it routinely, except within a context of a trial, until we really know what to do with the information that we have at hand at this time. And in patients without an indication for oral anticoagulation, as I said, there was a higher non-cardiovascular mortality compared to antiplatelet, and that we can't dismiss. We really need to look at it a little closer, and perhaps some other trials are underway. Next, we look at antiplatelet trials. There was a truckload of them, but the most important trials that were presented at ACC were three. And just to distinguish between them, one is the Twilight sex analysis. So this was a ticagrelor-based randomization. The host exam, which was really about chronic maintenance therapy in patients who have undergone percutaneous coronary intervention. And then the TALOS AMI, which was really about de-escalation. So these were really answering three completely different issues. The Twilight trial, what they did is patients who, it was a randomized trial, high-risk patients had ticagrelor and aspirin for 3 months. Those who had no events within the first 3 months were then randomized into either ticagrelor and aspirin against ticagrelor and Plavix, followed for 12 months, and then they looked at all the important endpoints. I do want to stop here at the characteristics and just point out a few differences here. One is, first of all, look at the number of women involved. And although this was a sex analysis, 23% only were women. So that's here in the blue bar. The women were also lower risk in terms of cardiovascular disease and comorbidity. So previous MI, 20% as opposed to 31%, previous CABG, and so on, and stable disease. When you look at the bleeding endpoint by sex, women clearly, with whichever definition of bleeding you use, had higher bleeding compared to the men. When you look at the pre-specified ischemic endpoints by sex, they were comparable in this trial. So women had a higher bleeding. The investigators say that this is attributable to the baseline differences, but bear in mind what I told you, that these women actually had lower risks and no prior MIs and so on. The ischemic events were similar between them, and this is a high-risk population. So this is not a trial that you take away and you can apply it across the board for your run-of-the-mill PCIs and your run-of-the-mill patients. Again, when you look at the differences between the number of women that were enrolled and so on, and men that were enrolled, what you can tell is that this was not a pre-specified analysis, and so I'm not sure it was powered to give us all the answers that we actually need. The other thing that I caution from is that we cannot start making conclusions about the role of ticagrelor in women compared to men otherwise. The important limitations here is, as I said, the sex differences were not individually powered, and so we can't really have definitive conclusions. Randomization was not stratified by sex, and so that is one of the hugest limitations of this analysis. And then it's not something that you can use for your random patients. This is really for patients who are high risk for bleeding and ischemic events. The next one is the host exam, which, as I said, is for chronic maintenance therapy. Over 5,000 patients were randomized after about 6 months to 1.5 years of their index PCI where they had no clinical events. That's when they were enrolled. So if they were enrolled at that point in time to clopidogrel and aspirin, they looked at the usual endpoints for MACE at 2 years. Remember, this was a low-risk Asian population. So the number of patients who actually had bifurcations, left main stenting, chronic total occlusions, et cetera, was actually a very small percentage. 5,000 patients, you ended up with about 2,700 in each arm and followed up for approximately 24 months. So when you look at the primary outcome, all-cause mortality, non-fatal MI, strokes, and readmissions and bleeding included, clopidogrel did much better than aspirin. After 12 months, when you look at the graphs, you look at the lines, they actually separate. This is a secondary prevention trial, and it was you see it again when you look at the secondary outcomes separately, the thrombotic outcomes and the end bleeding. They separate, and more so after 12 months and continue after 24 months. Should this trial have been continued even longer, we may have seen the lines separate even more. So really, this is clopidogrel monotherapy compared with aspirin. Thrombotic composite endpoints and bleeding were better in the clopidogrel arm. Long-term follow-up, although this is what the investigators suggest may be more concrete information for us. There was a lot of question and debate about whether this is the Asian paradox, etc. But remember, we're talking about secondary prevention, so we're not talking about peri-procedural events. These are patients who had no events after 6 to 18 months. So perhaps we're no longer talking about the same issue at this point in time. TALOS AMI, again, this is a study that actually looked at de-escalation. It's very important because there was a significant decrease in bleeding risk and no increase in ischemic risk in these patients. So what they ended up doing is, again, after the index PCI, there was a screening period of approximately 1 month. Patients who had no adverse events at that point in time were randomized to either de-escalation, where they were initially on aspirin ticagrelor. Some were de-escalated to aspirin and clopidogrel, and the others continued on aspirin ticagrelor dual antiplatelet therapy and continued for 12 months, and then they looked at these patients' events. So when you look at the composite cardiovascular death, non-fatal MI, stroke, and BARC bleeding, it was lower in the de-escalation compared to those who continued on the intensive antiplatelet therapy. Likewise, when you look at them in terms of bleeding and you look at them as the secondary endpoints and you separate cardiovascular death, MI, stroke, and then on the other arm you look at the BARC bleeding, once again, you can see that the difference was significant and de-escalation tended to do better. I think to keep this in context, a lot of us in clinical practice do shift our patients primarily because we're concerned about stopping aspirin. The debate isn't over about abruptly stopping aspirin. And I think what people are doing is converting because of tolerance and expense of the ticagrelor itself. Next is Disrupt Trials, which is a core interventional trial. This is about the intravascular lithotripsy. They looked at 1, 2, 3, and 4 of these this modality of treatment. What caught my attention is that acute success was very high, but the acute lumen gain with IVL alone was surprisingly very good, even before, after, without stenting. So obviously with stenting, the minimum lumen diameter was even better, but the gain with this therapy alone was actually remarkable. The safety endpoints were fantastic. 30-day outcomes were actually also very good. I think what this is just pooled outcomes really that where everybody's looking at. These are patients that are actually high risk, and these are high risk procedures. So remember, you're not going to use atherectomy devices or debulking therapies except in patients with calcifications, with bifurcations, and so on. And so it is interesting that yes, they may have higher MACE, but overall their success rate was very good for this therapy. So the armamentarium in the cath lab now has become humongous. The Society of Cardiovascular Angiography has elaborated an algorithm on what to follow. We need to know how it works in terms of, rotablation, lithotripsy, diamondback, etc. Intravascular imaging will help us determine that. Not every lab has to carry everything. Not every patient has to receive all therapies. Bear in mind which tools work and how they work, but also the cost. And I think this is something that often we don't discuss enough when we look at devices and their approval, is cost effectiveness. I'm going to try to wrap up with this, and I know this is a very important area, the significance of FFR-guided PCI. There are two subsets of patients, and we cannot confuse them. One is acute coronary syndromes and that of chronic coronary syndrome. So acute coronary syndrome was the Flower AMI and the Future trials, and chronic coronary syndrome was the ischemia complete revascularization. Those were the ones that were presented at ACC this year. Flower AMI, again, courtesy of PCR Online and Dr. Nazmi. It was a prospective randomized trial, 1,100 patients, randomized to either FFR-guided or angio-guided. They looked at one-year outcomes in terms of death, revascularization, non-fatal MI, etc. And basically what they saw is that the FFR-guided was not superior to angio-guided in patients who had a STEMI. So these are patients who had STEMI and multi-vessel disease, and the whole idea was the non-culprit lesion was going to be evaluated using FFR. So it was found to be more expensive, but really not superior in terms of outcomes. The other one is the ischemia complete revascularization. Again, what they did is they tried to look at the subset of patients who ended up getting invasive therapy, and they looked at them, and the endpoints were, again, the similar cardiovascular death, MI, hospitalizations, and so on. And they looked at complete revascularization as opposed to incomplete revascularization. And they also looked at it in terms of anatomic complete revascularization, so that is angio-guided only, and looked at 4 years out. And they saw that the event rate was actually higher in the incomplete revascularization, so complete revascularization tended to do better. The functional assessment in these patients, once again, at 4 years, you see that complete revascularization did better compared to incomplete revascularization. However, the anatomic did much better than the functional. So this suggests that select patients with chronic disease and moderate ischemia, because again, this was the ischemia trial, the outcomes of the invasive strategy improved if the anatomically guided revascularization was performed. This was not a randomized data set, so we have to interpret it with caution. Functional assessment does not necessarily mean invasive assessment, i.e. it's not the equivalent of FFR and IFR and so on. FFR and trials such as the FAME trials and so on, those were actually used for chronic coronary syndromes, and some of the analyses that came out later saw that the benefit was incremental, and it was at a later time. So I will stop here so we can move on to our next speaker, perhaps.
Thank you so much, dear Mirvat. It was an excellent presentation. I have the pleasure to present to you Dr. Kamala Tamirisa from the US, which will present to us updates in arrhythmia. I would like to remind you that you can ask your questions in the conversation panel. So, Tamara, you have the word. Okay, so maybe you should unmute yourself. We can hear you.
Can you hear me?
Yes.
Okay, can you see me now? I apologize, it's the laptop and I'm at work. Okay, so mine will be pretty short, unlike Mirvat. EP, we don't have that many major trials, but I'll start with the Laos 3. Laos 3, in Laos 3, they looked at patients with AFib and on all types of AFib, on oral anticoagulants who were undergoing a routine cardiovascular surgery. And their question was, if patients are already on anticoagulants and you occlude the left atrial appendage, is there a benefit in reducing ischemic stroke or the systemic embolism? It's a multi-center randomized control trial. 4,811 patients were enrolled. Follow-up was for 3.8 years. And key points to remember in the enrollment is the CHADS2 vascular risk score is mean CHADS2 vascular risk score was 4.2. That's very important to remember. And the mean age is, these were not younger patients. They were 71 years was the mean age. The sad part, of course, is only 1/3 of the enrollees were women. And the key points to ponder as you look at this trial, the cardiovascular surgery was not limited to bypass alone. Only 20% had pure bypass, and rest of them were valve replacement combined and other valve surgeries, including mitral valve surgeries. 77% of the patients continued oral anticoagulants at 3.8 years. And moving on to the results, there was 33% relative risk reduction with concomitant left atrial appendage occlusion with a hazards ratio of 0.67. And that's remarkable. And another beauty with the way they analyzed the data is they did a landmark analysis at 30 days. And that was done to tune out noise, postoperative noise. And that actually showed a greater relative risk reduction of 42%. There were no change in heart failure incidence. Why is that important? We know that the left atrial appendage is rich in A and P, and interesting to see that there was no change in heart failure incidence. There were no significant difference in intraoperative bleeding or complications or the cross-clamp time, and as we know, that adds to stroke risk, and the complication rates were similar. So the key points are the number needed to treat. What do we take from that? 37 patients need to be treated with left atrial appendage occluder on top of anticoagulation over 5 years to reduce one stroke. And there appears to be an additive benefit of occluding that left atrium on top of continued anticoagulation in these patients. And caution here is the trial is not meant to compare the direct oral anticoagulants with the left atrial appendage occluders. And so I'll jump on to the next one. And if anyone has questions, you can just type it up. But moving on to the, this I thought was very neatly done, small study looking at acute alcohol consumption and AFib events. That's a holiday monitors study. We know anecdotally binge alcohol intake is associated with AFib. This study validated the holiday heart syndrome, and they looked at 100 patients. These patients were monitored continuously with different techniques, and they were also, they underwent transdermal alcohol sensor placement on their ankle, and the patients were instructed to press the button on their monitors each time they took alcohol. And to corroborate the self-reported drinking events, these patients also underwent PET, which is one of the alcohol metabolites finger testing done twice a month. So the key findings were more than half of the patients, one drink before that, I don't want to delve too much into it, but one drink, key points to remember, one drink was associated with a twofold greater folds of AFib episode and more than threefold increased risk of AFib with patients who had 2 or more drinks of alcohol. And the temporal relationship between the alcohol intake and the onset of AFib is 4 hours, within 4 hours. With every 0.1% increase in blood alcohol concentration over 12 hours, there was a 38% greater odds of having an AFib episodes. Obviously, the take-home points as an EP physician is, educate patients and tell them, lifestyle, change is super important. And I would be very interested to see this data extrapolated to post-AFib ablation. Should we start telling patients not to drink alcohol for a month or 6 weeks? That would be cool to see. Moving on to the next one is the Raft Af. This is a negative trial, but there are a lot of take-home points in this trial. This trial compared safety and efficacy of ablation-based rhythm control compared to rate control for patients with AFib and heart failure. And they subdivided that with a cutoff of 45% of EF. And they enrolled 411 patients and they followed them for 37 months. And the results were not great because they could not continue for 5-year follow-up. They could not enroll the number of patients they wanted to enroll. The trial was terminated early due to low enrollment and futility concerns. Even though the event rates were lower in the ablation arm, the primary outcome of death and heart failure events were not statistically significant. But I don't want the readers and all of us to lose the sight of the secondary outcomes. The secondary outcomes actually were in favor of rhythm control. Improved EF, 6-minute walk test, heart failure class, and reduced serum biomarkers were noted, which points to the fact that EP physicians say rhythm control is much better than rate control. It's always AFib is abnormal, sinus rhythm is normal. And, I don't have enough time to delve into the Castle AF or the Cabana AF to put that into perspective. But when we look at this trial, it's important to look back at the East AF Net4 trial, which also pointed that rhythm control is better. So even though not statistically significant, rhythm control did fare better than the rate control. And thank you, Alex.
Wonderful. That was great. Thank you so much. So it's my great pleasure to introduce our next speaker, who is Dr. Nazaren Ibrahim, who is in Northern Virginia in the United States, who's going to tell us about the late-breaking clinical trials related to heart failure. Nazaren?
Just want to make sure you can see my screen.
Yes.
So I will be spending 5 minutes going through a whirlwind of what's new in heart failure from ACC 21, and I will start with Galactic. So Galactic HF, as you know, the original presentation, it was patients with omecamtiv with heart failure with reduced ejection fraction were randomized to receive omecamtiv mecarbil or placebo. Omecamtiv, as you know, is a selective cardiac myosin activator, and in the original trial, there was significant reduction in the primary composite endpoint of first heart failure event or cardiovascular death. So the question for this pre-specified subgroup analysis was to determine whether the therapeutic effect of omecamtiv changed depending on EF. So as you can see here, there was an increase in treatment effect as the EF got lower. And in the lowest quartile, EF 22% or less, the number needed to treat to prevent one heart failure event or cardiovascular death over 3 years was 11.8. What was important is that there was no difference in adverse events, including blood pressure reduction, worsening of renal function, and increase in potassium, which is very different than the side effects of the current GDMT that we use. So is there a place for omecamtiv mecarbil and the armamentarium in treatment of patients with heart failure with reduced ejection fraction? I would say potentially, especially in patients that don't tolerate traditional guideline-directed medical therapies and in patients with severely reduced ejection fraction. As we can see, the effect is greatest when the EF is lower than 30%. So Soloist and Scored. Soloist was sotagliflozin in patients admitted with heart failure, with acute decompensated heart failure, and Scored was patients with diabetes and CKD started on sotagliflozin. So pooled data from both trials shows that patients who received sotagliflozin had a significant reduction in total cardiovascular death, heart failure hospitalization, and urgent heart failure visit compared to placebo. And when we looked at only the patients that had heart failure, which was about 4,500 patients, the effect of sotagliflozin in reduction of total cardiovascular death, heart failure hospitalization, and urgent heart failure visit was also significantly reduced compared to placebo. And importantly, this effect was consistent across ejection fraction. So in patients with EF that was less than 40%, patients with preserved ejection fraction, and also patients with this mildly reduced ejection fraction from 40 to 50%. Very important to note that in on-treatment analysis in patients that did have a history of heart failure, there was significant reduction in cardiovascular death. Again, in all patients in both trials in this pooled analysis, there was a significant benefit of sotagliflozin across the spectrum of EF and also in men and women. So sotagliflozin robustly and significantly reduced the composite endpoint, which was total cardiovascular death, hospitalization for heart failure, and urgent visit for heart failure. As I mentioned, in on-treatment analysis, sotagliflozin also demonstrated a significant reduction in cardiovascular death. The great thing about this trial is we saw that the benefit was consistent in men and women, but also the question becomes, does sotagliflozin help patients with HFpEF, since we currently have no guideline-directed medical therapies for HFpEF? So the LIFE trial, this was sacubitril valsartan in patients who had stage D heart failure, and this was a negative trial. So they were randomized to receive sacubitril valsartan or valsartan. The primary endpoint here was area under the curve for the change in NT-proBNP from baseline through 24 weeks. It was a small trial, 335 patients were randomized, but neither treatment with sacubitril valsartan or valsartan decreased the median NT-proBNP at 24 weeks. Also, there was no difference in days alive out of the hospital or free from heart failure events. There was also, it was tolerated in both groups, but there was increase in hyperkalemia in patients who received sacubitril valsartan compared to valsartan. There was no difference in cardiovascular death or heart failure hospitalization, and there was no difference in heart failure hospitalizations. Again, these are the sickest patients with stage D HFrEF that we're usually evaluating for transplant and VAD, so I don't think it was surprising that we didn't see a difference with sacubitril valsartan. Rehab heart failure was a trial of a physical rehab program that was specifically for older heart failure patients hospitalized with acute decompensated heart failure. The regimen included exercise and balance, strength, mobility, and endurance. The primary outcome was change in SBBP, which is short physical performance battery. And as you can see at 3 months, there was improvement in patients who were part of the rehab intervention. Additionally, there was improvement in 6-minute walk distance, frailty, depression, and KCCQ scores in patients that were enrolled in the program. What was really great was that it was a diverse, older patient population, but that the intervention was feasible in both tertiary care and community hospital settings, and there was excellent retention and intervention adherence. So great news for older patients hospitalized with acute decompensated heart failure. Lastly, Connect Heart Failure was presented by Adam DeVore, and this was a study patient of U.S. hospital systems, and this intervention was a system-based intervention for quality improvement in the uptake of guideline-directed medical therapies. The co-primary endpoints were composite of heart failure hospitalization or death, and change in an opportunity-based composite score for heart failure quality. So this was another negative trial in heart failure, so there was no difference in the primary outcome of heart failure hospitalization or death between the usual care arm and the intervention arm. And there was no change in the uptake of guideline-directed medical therapies that we know reduce morbidity and mortality. So important because GDMT uptake has been poor across the United States, and implementation trials are needed to see how we can improve uptake of GDMT across hospital systems. What's notable here is they talked about the fragmented nature of heart failure care in the US, which was very apparent in this study. So that's it for heart failure.
Alex,
I think you're on mute.
Alexandru, you're still on mute.
Okay, you can share your screen, Daryna.
Oh, yes.
Okay.
And you were on mute, so we missed your introduction. Can you introduce her again?
Yes, so we will be hearing updates on cardio-oncology from Dr. Daryna Chernikova from Ukraine.
Yes, it's okay?
Yeah, perfect.
Okay, yes. Okay. One moment. Yes. So dear colleagues, it's an honor for me to be a part of such professional and enthusiastic team of the telecardiology working group, and today I would like to present the updates in cardio-oncology that has come into focus of world cardiology community this year. So let's start with modern therapy. After a modest early signal of benefit, candesartan showed no effect on key markers of heart health 2 years after treatment in patients with early stage breast cancer in the randomized BROTHER trial. It was the largest randomized trial in breast cancer to look at the effects of candesartan and metoprolol, both against placebo on cardiac dysfunction. The patient has adjuvant cancer therapy with anthracyclines with or without trastuzumab and radiotherapy, all well known to have cardiotoxic adverse effects. Novel cancer therapy represents a new frontier for investigation. The use of immune checkpoint inhibitors is associated with a threefold higher risk of cardiovascular events. ICR-related myocarditis has a reported incidence of about 1%, but it has significantly higher associated mortality of 25 to 50%. Main risk factor for development of myocarditis is combination of CTLA-4 and PD-1 inhibition. At this time, 5 major National Institute of Health-sponsored oncology-based trials with integrated cardiovascular outcomes are now underway, a feature that has not previously been included in conventional oncology clinical trials. Now we have the result of multi-center cardiac safety study Berenice. Dual EGR2 blockade with pertuzumab and trastuzumab on top of anthracycline-based neoadjuvant chemotherapy for early-stage breast cancer was associated with a lower rate of clinically relevant cardiac events in the final follow-up. If we look at other trials that have also tested dual EGR2 blockade, all of them ratio that dual blockade is not more cardiotoxic than single blockade. Here you can see the key points of new position statement of the American Heart Association regarding the impact of hormonal therapy for treatment of hormone-dependent cancers, such as prostate and breast cancers on CVD. For patients who have 2 or more cardiovascular risk factors, it's likely that referral to a cardiologist would be appropriate prior to beginning hormone therapy treatment. There is the most comprehensive toolkit for prevention strategies in cardio-oncology and some critical take-home message for the field. First, we need to target cardioprotection therapy according to risk and personalized therapy. Also, there is a need to design CV prevention trials in oncology patients based on their cardiovascular risk. Thank you so much for your attention.
Great, thank you so much. So next we're going to have Dr. Aaysha Caderr from Bangladesh, who's going to tell us about late-breaking clinical trials in COVID.
Thank you so much for the introduction, Erin, and thank you, Alex, for having me. Can you see my slides?
Yes.
All right, so I'll just discuss a few trials predominantly around COVID. Unfortunately, not a great many positive trials, but let's start with the anticoagulation coronavirus or ACTION trial, which was presented by Dr. Renato Lopez. And it was a randomized clinical trial looking at the perennial question of routine prophylactic versus therapeutic anticoagulation strategy in hospitalized COVID-19 patients. They randomized 615 patients to a therapeutic versus prophylactic arm. And within the therapeutic arm, there was a further subdivision of stable versus unstable patients. Stable patients were given rivaroxaban 20 milligrams daily, and unstable patients were given low molecular weight heparin of enoxaparin in a routine twice daily 1 mg per kg dose, followed by rivaroxaban for 30 days. So the primary outcome here was a hierarchical analysis of mortality, duration to hospitalization, and the duration of oxygen used through the 30 days. And the statistical analysis was interesting in that they used an unmatched win ratio to report the primary outcome measures. Basically, a win ratio, if it is greater than 1, it reflects a better outcome for the treatment being studied. And as you can see, there were 34.8% wins for the therapeutic arm and a greater number of wins for the prophylactic arm. So this was, in effect, a negative trial for therapeutic anticoagulation. These are the separate components of the primary outcome, which show similar patterns in terms of win ratios. As for 30-day mortality, There were numerically high rates of 30-day mortality in patients assigned to the therapeutic arm, but this was not statistically significant. And in terms of efficacy, those who were assigned to the therapeutic arm had numerically lower thromboembolic events, but then this was against a significantly greater major and clinically relevant non-major bleeding in patients assigned to the therapeutic versus prophylactic arm. So in effect, this was in general a negative trial for therapeutic anticoagulation because it did not improve clinical outcomes and was offset against a greater risk of increased bleeding compared with in-hospital prophylactic anticoagulation. Moving on to DARE 19, which was also a negative trial, but we have a tendency to believe that SGLT2 inhibitors can work wonders on everything. So this was a global trial which randomized 1,250 patients equally to dapagliflozin versus placebo, based on the hypothesis that it might reduce the risk of multi-organ failure and death and improve recovery in patients hospitalized with COVID-19. And all of these patients had either one or more cardiometabolic risk factors, that is either hypertension, type 2 diabetes, ASCVD, heart failure, or CKD. So it was a high-risk population. They had two dual primary endpoints, the preventive one being time to first major clinical event, organ failure or death, organ failure being one of three, either respiratory, cardiovascular, or kidney decompensation. As you can see, this was not met, nor was the primary outcome of recovery, which showed a non-significant win ratio of 1.09. This is the Kaplan-Meier curve for one of the composite secondary endpoints, which is the kidney endpoint. This is again exploratory, given that the primary endpoint was not met. However, it is the safety signal here that is key, with dapagliflozin arm experiencing numerically fewer events as compared with placebo. Similar case for mortality. And as I mentioned, safety is a critical issue. There were fewer side effects, fewer adverse outcomes with an outcome of death, fewer discontinuation due to an adverse outcome, as well as acute kidney injury in the dapagliflozin arm compared to placebo. There were only 2 patients with DKA in the dapagliflozin arm, and these patients had a history of DKA from before. So this is again a largely negative trial, which did not achieve statistical significance, but I think it's the safety data here that yields important practical implications, because these results do not support a prevailing notion that SGLT2 inhibitors need to be discontinued in the setting of hospitalized COVID-19 patients as long as they're monitored. And that's perhaps the most important takeaway point from this. Lots of other drugs have also been investigated in relation to COVID. Very quickly, the Inspiration-S trial. This was a multicenter randomized clinical trial of COVID-19 positive patients admitted in the ICU, where they randomized 605 patients to atorvastatin 20 milligram once a day versus placebo. The primary outcome was a composite of all-cause death, venous arterial thrombosis, or treatment requiring with ECMO, which occurred in 32.7% in the atorvastatin arm compared with the 36.3% of the placebo group, but this was not statistically significant. Very quickly, I'd like to run you through the Capital Chill trial coming in from Canada. This was a randomized controlled trial of out-of-hospital cardiac arrest patients who were randomized to mild versus moderate therapeutic hypothermia, mild being 34 and less, and moderate being 31. This was actually the first RCT to evaluate the benefits of therapeutic hypothermia with target temperature below 32 degrees. The primary endpoint was death or poor neurologic outcome at 180 days. This was not met, as you can see in the graph, and these are the Kaplan-Meier curves for survival at 180 days. The trial concluded that in comatose survivors of out-of-hospital cardiac arrest, moderate hypothermia of 31 degrees or less was not superior to mild hypothermia in improving mortality or neurological outcomes at 6 months. I'd like to leave you finally with this very sobering data from the Global ACC Wellbeing Study. It's not a trial, but it's important data in the context of COVID and in the context of physicians. It looked at the impact of the pandemic on the cardiovascular workforce internationally. These graphs essentially speak for themselves, showing nearly a 2-fold increase in burnout rates during the peak pandemic for all cardiovascular professionals. Respondents also highlighted the need for adequate measures to be taken by organization and leadership, and there was also a lack of professional contentment among burnout respondents, and indeed a huge emotional burden associated with burnout, with potential for downstream detrimental effects professionally and personally. So while we all go out and take care of patients, I know more than a few of us are quite stretched out, quite thin. Make sure you look after yourselves. Stay safe, stay healthy, and hopefully we'll meet again in person soon. Thank you.
Alex, you're on mute.
Okay, so sorry. Thank you so much, dear Aaysha. I have the pleasure to present Dr. Florian Zores from France, which will present updates on hypertension. Hi, Florian.
Hi.
You can share your screen whenever you can. Thank you.
Okay, let's go. So I will talk to you of update in hypertension. So there is only one randomized trial in this ACC 21 on this subject, and it was Radiance trial. It's a double-blind randomized sham-controlled trial, and it's important to underline this double-blind design because simplicity was only a single-blind trial, and double-blind because patients were blinded and usual caregiver were blinded too. So the design is this one. So patient with resistant hypertension and under 3 medication were screened, and they were given a fixed dose 3-drug combination of amlodipine, valsartan, and hydrochlorothiazide, and were randomized only if blood pressure was still high under this fixed treatment. And they were randomized on renal denervation or sham procedure. And the primary efficacy endpoint was the delta in daytime ambulatory systolic blood pressure at 2 months. In simplicity, the criteria, the primary efficacy endpoint was at 6 months. I will obesity for 80% of patients with a BMI of 33, and sleep apnea and diabetes in about 50% of patients. So, what is the efficacy of this procedure? So, in patient with renal denervation, there is a greater reduction of the blood pressure than in patient with sham procedure. For these 2 first months of the trial, all patients were under the fixed dose 3-drug combination, valsartan, amlodipine, and hydrochlorothiazide, and no other treatment were allowed except for patients with hypertension higher than 80/11. And for this patient, there was a possibility to add a medication, and it was mainly spironolactone. And you can see there is more patient in the sham arm to receive spironolactone than in an intervention group. So what we can see, it's this trial has an efficacy on all secondary analysis on office blood pressure, ambulatory blood pressure, all-day blood pressure, and so on. And the conclusion is that in patients with hypertension resistant, renal denervation is effective, but it's only a surrogate endpoint because there is no analysis of events. With a very short follow-up of 2 months, Simplicity was a 6 months follow-up with many more patients because there is 500 patients in Simplicity. And we must wait for more analysis because more analysis are scheduled in 6 months and more. And after these 2 months, patients were allowed to receive more treatment like spironolactone if hypertension is not controlled. So we must wait for more robust endpoint and more longer follow-up.
Great, thank you. So it's my great pleasure to introduce our last speaker, Dr. Biljana Parapid from Serbia, who's going to be telling us about the late-breaking clinical trials in the field of prevention. Biljana?
I unmuted, sorry, I forgot. I'm not going to show you the slides. I'll try to cut my talk short so that we can discuss. And also, I think we should definitely have Dr. Raghi join us afterwards for discussion as always. So Florian, thank you so much. I'll just keep with hypertension briefly, just a bit. It was not a late breaker, but it was those were results from Dr. Aito Kalilo from from Finland, and they presented actually sex differences in genetic risk for hypertension. And what they have shown for folks who are not into cardiovascular epidemiology like I am, because I do run trials of the kind, is they have 50-year follow-up actually of their own 200,000 patients, where 56% were women, and they had an incidence in 50 years of 22% of incidence of hypertension for women and almost 30% for men. Now we know that the trajectory is different in men and women, and what they have shown is that they calculated actually sex-specific polygenic risk scores for systolic blood pressure, which turned out to be more profoundly associated with women than men, and particularly early onset hypertension, which in a way mimics our own 45-year results of the 7-country study, where we have shown actually that men, although those were just men included there, we presented a couple of years ago at ESC, whose mothers had a burden of hypertension and cardiovascular disease had more pronounced hypertension and cardiovascular disease also. So it's interesting to show it in Finland this time. Finland was not included in our cohorts. Finally, Holiday was presented by Dr. Tamirisa brilliantly. I will just touch briefly on something that is also a genetic study run by Dr. Mizzou from Mass General. It was not a late breaker, but I think that we should also mention it. They report their own Mass General Brigham Biobank, where they have found moderate alcohol to be associated with lower MACE after adjustment for lifestyle and CVD risk, and with a lower stress associated neural activity, where they found the latter being the mechanism for the former. Now, fortunately, they don't advise us that we should consider it as a therapeutic option, but I think it's something that we should also mention. Dr. Chevy discussed diabetes heart study, which is one of the rare things where we have seen the population really mimicking the population we see in United States clinics. They had African-American descent population that was more present than the European ones. They had 437 African-American patients included versus 262 of European descent. They have been all analyzed for metabolites and coronary artery calcium, showing that no metabolites were higher in European African-American. Androgenic stereometabolism was associated with calcium scoring in both groups, but their lipid metabolism subpathways were different. So it definitely calls for more epidemiological and more trials, including what we used to call minorities, but those are not minorities, those are just our populations. So I will try to introduce it for the discussion because I'm cutting this short, but I would like to pick Dr. Michos' brain on that, because that's been a big during ACC on Twitter and everywhere. But I would just like to mention also a study run in Intermountain by Dr. Vietle, where they showed 10-year follow-up results in which they it was a population of patients who had angiographically confirmed coronary artery disease, and their reduction in MACE, in particular survival, was more pronounced in those who had higher levels of EPA, while higher levels of DHA when adjusted for EPA and comorbidities increased risk for MACE. So before I close with aspirin and adaptable, I would just like to mention that one of the rare reports we have seen that discusses diet as an intervention at all, which is a pity, was Dr. Hensel's report, which is just appeared in JACC in current edition, and they actually randomized their patients to lifestyle intervention being DASH plus optimal medical therapy and optimal medical therapy alone, and they have shown reduced atheroma volume and plaque composition in those who were following the composite trial. And finally, adaptable tested, as we have seen, 2 doses of aspirin, the 81 milligram and 325, which we don't have worldwide. But Dr. Marana also mentioned something wise on Twitter, and that is absolutely we should at least stick with 81 milligram. They have shown in 15,000 patients. What is novel about this, it was a pragmatic trial. It was completely web-based. And although almost 500,000 people were asked whether they would like to join, 15,000 eventually did join and didn't follow the follow-up. So in the 15,000, no observed difference was in death, MI, and stroke. And with this, I think I kind of made it under 5 minutes, and I will give it back to Dr. Michos and Dr. Mischie. But before that, just one thing, I think we're living in an amazing era. I deliberately put this background behind where we have seen one Madam President passing the baton to another one, and our new Madam President, as if anyone didn't notice, is actually applauded us for joining here tonight, and that's why I posted this tweet in the background. So kudos to all the amazing who inspire us.
Thank you so much, Biljana. Thank you. We saw excellent presentations. We have 10 minutes for discussions and questions. Please keep the answers very short, under 30 seconds. I would have the first question for Erin. So Erin, what would you think that would be the highlight of the Congress? What would be the trial that is the most interesting trial presented at the Congress?
Oh, well, that's a tough question. There's so many interesting ones. I think I'm excited about the SGLT2 inhibitors, that we may actually have something that works for HFpEF, as you heard from Dr. Ibrahim. Also, although dapagliflozin didn't work in COVID, I think we learned a lot of important data about that at least safe to continue these medications in hospitalized patients. I'm also really excited about finerenone potentially reducing the risk of AFib for patients with diabetes and CKD. There just was a lot of great science, and congratulations again to our wonderful panelists today that with the tour de force went through a lot of material in a really short period of time. But I wanted to turn over a question because I think Dr. Mirvat Alasnag has to leave early, and so I wanted to ask her one question that came up from the audience. So an audience member was wondering if you could clarify the DAP strategy in the first 3 months after PCI and after 1 year with the information that was presented. Has there been any change, and what is the strategy?
So for the first 3 months after PCI, dual antiplatelet, and it would consist of aspirin and a P2Y12 inhibitor. Now the choice between a more intensive P2Y12 inhibitor, be it ticagrelor, for example, or clopidogrel, is debatable. But after 3 months, or in terms of chronic maintenance, I think the suggestion now is perhaps we've been doing it wrong all along. Perhaps we should have been doing clopidogrel monotherapy rather than aspirin monotherapy, because both ischemic events were lower and safety-wise in terms of bleeding events were lower, surprisingly. So it's just a matter of getting your surgeons now convinced to operate on clopidogrel. Or if a patient who's on chronic maintenance ends up requiring some kind of surgery, then perhaps consider switching to aspirin temporarily and then resuming clopidogrel. So it's something that still needs to be debated, I suppose, or ironed out later.
Great. I'd like to say hello to Professor Hani Raghi from Egypt and to Professor Annabelle Valdman from the US. Welcome. Thank you for joining us. So further on, I would have a short question, hopefully a short answer for Nasrien. Can you tell us, please, what is the exact role of Entresto right now in 2021? What are the indications? Because we saw that in ischemic cardiopathy, things are not so well.
So I still would say, per the guidelines, the US guidelines, the New York Heart Association class 2 patients with EF 40% or less, but we did see that there is potential benefit in higher LVEF as well, so less than 50. So per the drug company indication, they have it written as an indication for patients with an EF less than 50%. But whether or not insurance companies will write that, whether or not the guidelines will change based on that, but I would say clinically in patients less than EF 50% in my personal practice that are their insurance will cover it, I start them on sacubitril valsartan, but per the guidelines, it's 40% or less.
Great. So I had a question for Dr. Kamala Tamirisa. This is an audience question about the Raft trial. Is there a subgroup of patients where ablation is effective?
Absolutely. It was usually with the EF of less than 45%, it's more effective. But then, the events were so low, we can't conclude much from this trial just because of the futility concerns, the drop off. But if you look at Castle AF, that I think was neatly done. Yes, someone could argue with me and say, well, it was a device-sponsored study. Independent of that, Castle AF has shown us anyone with a lower EF, less than 35%, here they took 45%. You have AFib, definitely the benefit is much higher. The lower the EF, the rhythm control plays a major role.
Thank you so much, Kamala. One short question and one short answer for both Florian and Biljana. So it's over with the high dosages of aspirin, as I understand it, yeah, or not?
Okay, Mirvat already answered it in the chat box. I think that it's, well, surely not the last we have seen of 325 for who needs it. But 25 just to be safe, then sorry, I don't think so, because it definitely generates a bleeding risk. And also, I haven't seen the sex analysis over there. I went through all the slides, maybe the ones that they have shown. They haven't actually shown us how many women were truly included. I saw a tiny branch of what was the full sample. So I don't think that 700 women here and 700 women or 300 women there were the total of the 15,000. So I don't think, I don't think that they're gone for good. Their 325 is still going to be there for who needs it, but definitely bearing in mind the risk. And let's not forget that all people who had an active bleeding in the past year were not included in the trial to begin with. So I don't think that it quite mimics the population that we see coming with STEMIs.
Thank you. So one question for Florian. Florian, in France, we have only 75 milligrams of aspirin. So in the adaptable trial, they used 81 milligrams. What can we do about this? Should we cut the pill?
We take 1.5 pills. I don't know. So in France, we mainly use 75 milligrams, and very few patients are under 325 milligrams. Personally, I never see any patient with this dose of aspirin.
Yeah, me neither. Thank you, Florian. So Erin, you have the word.
I think I have one last question. This is for Aaysha Caderr, Dr. Caderr, about these COVID trials that were negative, Inspiration and the recovery trial also a negative result for colchicine. So where are we now? So we know in really sick patients that steroids, dexamethasone works, but so where are we now with using anti-inflammatory drugs as therapy for COVID?
It certainly looks like it's continuing to be a string of negative trials, because I'm just a couple of days before Inspiration has reported a negative trial for statin, Recovery reported a negative trial for colchicine. But I think the bottom line is that we don't know the disease, we don't know what works, and it's important to try them not in an anecdotal manner, but in a randomized setting, so that we find the answers for randomized data, which is what we would consider gold standard of evidence. I mean, I don't think we can stop trying new drugs or investigating them, but it should be in a randomized setting as opposed to anecdotally or through experience or expert opinions, so to speak.
Absolutely, we need trials.
Thank you, Aaysha. So Professor Raghi, how are you?
Hi. Number one, please call me Hani, because I'm already old, and calling me doctor or professor makes me feel much older. And I call everybody with their first name, so please call me Hani with my first name. I'm very well, thank you, and thanks for the invitation. It was brilliant. It's just wonderful seeing all those faces of friends. I attended the ACC in full, and one of the things which I was interested in is who was sponsoring the trials, because I could smell a little industry in the negative sacubitril valsartan trials, where they were trying to expand the indication, where possibly, I don't know Nasrien, Dr. Ibrahim, her opinion on that, because we could have probably told them that the heterogeneity in acute myocardial infarction patients is so huge that they're bound to fail in the trial, which used Entresto early on compared to Ramipril in MI. On the other hand, we know that clopidogrel has lost its patency, so probably there's not so much industry interest. And I think that's important, because when industry starts trying to expand indications by doing possibly, I don't want to be harsh, but possibly silly trials. Negative trials chip at drugs. They really do. I mean, you have a drug which everybody likes, and you come to the most major meeting on the planet, and you have two negative trials on the same drug, it hurts it. Okay? So, you know, and possibly some of those trials shouldn't have been made. Again, doing trials, for instance, giving patients with COVID empagliflozin, dapagliflozin, you know, Forxiga. Why? I mean, why would you think that people with COVID would benefit from dapagliflozin? What is this? I mean, what are you trying to expand already the drug is a blockbuster drug, and you have so I'm curious to know, was the DAPA trial in COVID industry sponsored, or was it an investigator who thought of a brilliant idea? And those things are not very clear, and they're possibly hidden in the slide, on second slide or something, but they're not terribly clear. Again, if we bring a sample of the normal people walking in the streets and give them atorvastatin, they'll probably do well. But giving it to COVID patients, you know, it did not make sense. Waste of money and time. You know, I don't know. I mean, I'm sure the scientists behind this can explain it, but it doesn't make sense. It's just so good to see negative trials. I love seeing negative trials, because negative trials show our integrity as physicians. And I think this is very important. So for me, negative is positive, and I like the negative trials. Stay safe, and really thank you for having me. And everybody here was just so brilliant, you know. And Biljana, just for the record, you know, having the women doctors reach those positions so late, after so long, you know, being so deserved for so many years, is something which is making me so happy to see before I finally retire. Thank you.
Thank you so much. That's why I put it in the background, because I think that it will be some time again until we see a next president. I mean, that kind of a change. We're not saying that all previous men presidents were poor, just that there were also competent women for the position as well.
Of course, yeah. I mean,
there was something in the chat box. I don't know if Alex did, but that is Dr. Waldman wisely mentioned. What about the 50 milligram dose for women? Of aspirin, of course.
I can answer that, actually. I asked Dr. Braunwald about aspirin.
Oh, the lick?
I asked Dr. Braunwald directly, a personal question. And he said that he believes that it is enough to lick a tablet of aspirin every day as you're brushing your teeth in the morning for aspirin to work. There's no lower dose, because we were worried that like big, large men who weigh 140 kilograms or alcoholic, 75 or 51 milligrams would be too small for them. And this has never been proven, as an antiplatelet, aspirin works. And,
Amy, thank you for that response. I didn't know if I could speak, but it sounds like I can. Erin, maybe you will remember, but there was a women heart, there was a trial that looked at, it was based in Boston, And 50 milligrams was the dose that was used for women for prevention, and that showed benefit. And that's why I asked the 50 milligrams. So maybe a lick is as good, but I think we can try to do 50 milligrams. So based on that, I've asked manufacturers of aspirin here in the United States to see if they would create that dose, and they kept saying no. Maybe we should just tell them to break 100 milligrams if that's available here in the United States.
Yeah, I think in that women's health study, they used 100 milligrams every other day. So it came out to 50 average, but they did 100 every other day. Of course, 100 milligrams was what was evaluated in all of the aspirin trials that were in primary prevention that were mostly null in 2018 with Esprit and Ascend and Arrive. But that, of course, that's primary prevention. That's really different than adaptable. That was secondary prevention. But I think a really key point about adaptable, I think the biggest strength of adaptable is its design. But keep in mind the enormous amount of dose switching. And this was open label, and this was randomized but open label. So both the patient and the clinician knew what they were taking. So patients that might be felt to be at increased risk for bleeding or other things, switched to the lower dose. And so although there was no difference between the two doses, presumably higher risk patients were switched to the lower dose, because otherwise, how do you explain that there was no difference in bleeding? Because likely the high risk patients switched to the lower dose. So I think that we shouldn't make the assumption there was no difference between the two doses, that likely 81 milligrams is fine. But if a patient is tolerating 325 for secondary prevention and doing well on it, they don't necessarily have to change.
Okay, so we will see that in the following trials. So last word, maybe one question for Rafael and for Ritu. Would you think that artificial intelligence will have a big role in echocardiography? Do you think that in 5 years we'll have an echocardiographer just take 30 seconds to have a complete echo?
I think it will depend on the probe. I think if it's able to take all the information in one bit, but I'm sure that many things that we have now in our machines are based on artificial intelligence. So it's part of the things that we can do there. I think they will help us to do the things faster. Probably we need the hand of the human on some part of the interpretation, but I think it's possible. I'm sure Ritu thinks more or less similar, but let's see what she thinks.
I know that AI is actively being both studied and also being used. Certainly we use it for calculating ejection fractions. But where we're seeing it tremendous growth has been the last year has been using it in POCUS. So we are using AI software, and you can hand the ultrasound probe to a novice and actually be directed to get an EF that is the AI is directing it. And that has been a game changer. And of course, it's only come into play because of COVID. That was an incredible accelerator for this technology. And it continues to take over a large percentage of venture funding. And we're talking $1 billion plus industry that's only growing. So we'll continue to see more and more of that. And many different companies are in that. Besides Butterfly and Caption Health, GE just has a new machine out as well. So we're going to it'll keep growing.
Great. Well, wonderful comments, Ritu, Dr. Thamman, thank you for that. But I think we're out of time. So I want to thank again our amazing panelists who covered so much material from the great science that was presented at the recent American College of Cardiology meeting. So I want to thank our panelists, and I want to thank all of our audience members for tuning in today for this webinar.
Thank you so much, Erin. So see you next time on our webinars. Thank you to all the participants and to all the speakers once again.